Cephalosporins. The first cephalosporins were obtained from a fungus, Cephalosporium acrimonium. Later, semisynthetic cephalosporins were developed. Cephalosporins are beta-lactam antibodies with 7-amino cephalosporinic acid nucleus. The mechanism of action and development of resistance are similar to penicillins. Like penicillins, cephalosporins also inhibit cell wall synthesis and produce bactericidal effects. Cephalosporins are divided into 4 generations. First generation include cephalexin, cefadroxil, cefazolin, cephredin, cephalothene. The second generation include cefaclor, cefuroxime exetyl, cefuroxime, cefoxitin, cefotenin, and cefuroxyl. Third generation include cefixime, cefpodoxime proxetyl, ceftriaxone, cefotaxime, cefoperazone, ceftazidime, ceftriaxone, ceftidinir, cefibutane. The fourth generation includes cefepime and cefpyrone. Antibacterial spectrum. First generation show maximum antibacterial spectrum against gram-positive organisms, whereas fourth show least. Against gram-negative organisms, the first show least spectrum, whereas maximum spectrum is shown by fourth generations. First generation is effective against all the anaerobic bacteria except Bacteroides fragilis. Second and third generations show effectiveness against all the anaerobes including Bacteroides fragilis, whereas fourth generation do not show any effect against B fragilis. Against Pseudomonas, first and second generations are not effective, whereas third and fourth generations are effective. Against Salmonella, first and second are not effective, whereas third generation is effective. In beta-lactamase enzyme, among the first generations agents, cefazolin is highly susceptible to staphylococcal beta-lactamases. Cefoxitin and cefuroxime are resistant to beta-lactamases produced by gram-negative organisms. Most of third generation, most of them are resistant to beta-lactamases except cefoperazone produced by gram-negative organisms. Fourth generation show same effect as the third generation. First generation do not cross blood-brain barrier, whereas some of the second generation drugs cross blood-brain barriers like cefuroxime. Third generations like cefotaxime, ceftriaxone cross blood-brain barrier and are in high concentration in CSF. In fourth generation also crosses BBB. First generations are used in skin and soft tissue infections and in surgical prophylaxis. Second generations are used in respiratory tract infections. Cefotoxin and cefotetin are preferred for mixed like gram-negative and anaerobe intra-abdominal and pelvic infections. Third generation cephalosporins alone or with aminoglycosides are used in several gram-negative infections like pyelonephritis, gonorrhea, community-acquired pneumonia, typhoid fever, meningitis, mixed anaerobic and aerobic infections seen in patients with malignancy, septicemia, nosocomial infections. Fourth generations are also used same as third generations. They are also reserved drugs for hospital acquired resistant infections. Pharmacokinetics. Cephalosporins are administered either orally or parenterally. The drugs are excreted mainly unchanged through kidney, either by glomerular filtration or by tubular secretion. Some cephalosporins are metabolized in body before their excretion. Cefotaxime is deacylated in the body before its excretion. Cefoperazone is mainly excreted through bile. Like penicillin, the active tubular secretion of cephalosporin is blocked by probenecid, resulting in high concentration in blood and longer duration of action. Adverse effect. The most common adverse effect is allergic reactions. There are skin rashes, urticaria, and rarely anaphylaxis. Cross reaction to penicillin is seen in few patients. Gastrointestinal disturbances like diarrhea, vomiting, anorexia can also occur. Pain at the site of intramuscular injection, mainly by cephalothene. Intravenous cephalosporin can also cause thrombophlebitis. Nephrotoxicity is seen particularly in case of cephaloridine Because of it, it has been withdrawn. Co-administration of cephalothin and gentamicin increases the risk of nephrotoxicity. Intolerance to alcohol has been reported with cefotetin and cefoperazone. Severe bleeding can also occur either due to hypoprothromboanemia, which is respond to the vitamin K therapy, or thrombocytopenia and or platelet dysfunction.